So I'm going to assume that you guys have sat through at least some of the other presentations I've done over the year for Ameriserve. Um, the premise of the previous presentations was to uh, create a general understanding of how the Medicare system operates and how to access and navigate um, Medicare coverage. Uh, Today, I'm going to focus on the navigation part. The presumption that an individual has at some point already enrolled in Medicare completely, fully, and is utilizing the coverage to access healthcare services. Particularly, um, one of the most complex and expensive and uh, difficult processes in accessing healthcare, and that's accessing acute care. Now, that's nothing more than uh, a more technical term for going into hospital. And if you're lucky, you spend your whole life without going into hospital more than a simple outpatient process. But this is often where problems arise. Even individuals who have what is presumed to be excellent insurance or presumed not to be contemplating problems. However, before I get started, you'll notice there's my email address and the telephone number for our organization, Pennsylvania Healthcare Benefit Solutions Program. There's actually a letter missing. It should be phbsp.org. And if you reach out to phbsp.org or use that phone number, you can talk to me about whatever you want to talk about that we didn't have a chance to talk about today, or any other questions that pop up that you might not be sure of. So let me start by telling you a quick story. Katie and Jack. So Katie is a retired nurse. She's on Medicare at this point. And she also has an autoimmune disease. An autoimmune disease is where the body's immune system is attacking even healthy tissues and organs in the body. And in Katie's case, her immune system is attacking the connector tissues to her bones, joints. And if left unchecked, should ultimately look like a marionette with her strings cut. She certainly wouldn't be able to move without difficulty and possibly not be able to move at all. So she's on a regimen of medications, including immunosuppressants to tamp down the process of her body attacking herself. And she has to go in regularly, at least periodically, for maintenance surgery to repair some of the damage that her immune system does to her connector tissues. And normally, it's relatively straightforward. She goes in on day one, they operate on day two, and they discharge her if nothing goes wrong on day three. And or as long as she's been doing this, nothing's gone wrong, except last February, she was in for the maintenance surgery. And she went in on Thursday. The operation was on Friday, and they were expecting a discharge Saturday afternoon. Except that morning, Saturday morning, the morning of the discharge, when they did her vitals, they noticed that her pulse was elevated. Her heart rate was a little bit fast, but The most important thing was she had a fever, about 103. Now, normally, those indicators, especially for someone in her condition, would have stopped the discharge, would have compelled the hospital to keep her for some extra time to monitor the fever, probably administering antibiotics. But because the discharge was compelled by the insurance company, because everything was set for a few hours from that point, it was overlooked. And when finally the discharge was in process, and Katie's husband, Jack, said, look, I don't think she looks very good. They were told, hey, she's fine. Katie didn't put up much of a challenge because Katie wanted to get discharged. And Jack was, okay, I guess you guys know what you're doing. About 12 hours later, when Katie was home, her fever was up to 105. And by now, urgent care centers were closed. It was the middle of the night. Jack was panicking. Normally, Jack would have responded much earlier, but Katie was apparently sleeping and he didn't want to disturb her. What she was actually experiencing was the beginning of a systemic shock brought upon by sepsis. He called me, and the reason he called me was because not only am I friends with Katie and Jack, I'm also their patient advocate. And when he told me Katie's condition, her temperature, and that she was only semi-conscious, I said, call 911 right now. And he said, well, I could put her in the car. I said, no, call 911. I told him exactly what to say to the 911 operator. And the reason I did that is I wanted Katie coming into the emergency room in an ambulance because it's Saturday night in a large urban hospital. The possibility Katie could have been in the waiting area of the emergency room for an extended amount of time. And right now, this was serious, just the way Jack described it. And even though there was no certainty of what was happening, the elevated temperature alone was sufficient to treat this with expediency. When Katie arrived, and it was about 20 minutes from the time that the paramedics arrived, and they arrived about 15 or 20 minutes after the call was made, Katie went straight into the emergency room, and the emergency room physician told Jack that had Jack waited till the morning, had Jack waited for an extended amount of time, very likely Katie would not have survived. She was septic, and she was in the beginning stages of septic shock. And considering her condition and the other circumstances, or just even for a healthy person, that circumstance could be fatal. Katie stayed in the hospital for the second time for a bit more than 3 days. They ran an IV of antibiotics. They actually had her packed in ice for a bit of time to bring the fever down. And when they discharged her that Wednesday, within a few days after that, Katie and Jack received in the mail a statement from the insurance company. And the insurance company basically said that they were denying the coverage for Katie's second stay. And the reason they were doing it, according to the letter, is because She had been recently discharged, and there was no authorization for her to go back in, disregarding the fact that the emergency room physician said that she was septic and that she was at risk of dying. And I'll tell you guys, this is actually pro forma. Not in every instance, obviously, but it happens. It happens regularly. And you'll see why in a bit, why it was imperative for the insurance company, which also, by the way, happened to be affiliated with the healthcare system, which for this story will go unnamed, but you might figure it out. There was compelling reason not to recognize this as an official readmission into facility. And so not only was Katie brought to the point of nearly dying, not only did she have to stay an extra 3+ days in facility, but also now they were confronted with a bill for upwards of more than $20,000. Again, Jack called me and said, I don't understand. And said, let's call billing. Well, shouldn't we call insurance? No, we're going to call billing to find out if they've been notified. And in contacting them, we found out that, yeah, they had been notified. And the first inclination was for the hospital to set up a payment agreement with Jack and Katie. And my inclination was to explain to them that due to the circumstances and due to the risk that Katie was in, our next step was to file a complaint with the Centers for Medicare and Medicaid Services and bring a malpractice attorney into the process. And while Katie was in the hospital the second time, I made sure that we took screenshots of Katie's diagnostics, that the vitals, and as well as we scrolled through her information on her charts now are electronic, that I wanted to see the intake information. I wanted to see her vital stats. And the reason we were able to do that, by the way, is because, as I said, Katie used to be a nurse, and she used to be a nurse at that same facility. So she had a number of people that knew her quite well and were more than happy to make sure that Jack had the information necessary to point out to the hospital that this was not a simple process and this was not something that was taken lightly. Within 24 hours of reaching out to the hospital reached out to Jack and informed Jack that Katie and Jack would not be billed at all. The hospital would eat the entire cost. Now, that's not typical, but in this case, under the circumstances, it wasn't unusual either. But, and you'll find out later in a few minutes, it wasn't a challenge to the dismissal of coverage by the insurance company. It was a dismissal of the requirement that Katie and Jack had to pay the $20,000+. The stay was still denied. The insurance company challenged the whole premise of her being there. But it was the hospital that waived the requirement to pay. And I'll show you why that's important. I'll show you why the hospital would have rather let it stand as a denied reimbursement and just waived the cost to the family. And the reason I tell you that whole story is to give you an idea that no matter how well you're insured, no matter how well you think the process is going to go, And there's always the likelihood of some issue. And there's always the likelihood that that issue is going to be overlooked or minimized, no matter how serious it is, because intervening factors, economic factors, um, override the normal premise uh, of accessing the maximum level of care that one would expect. And it's not simply enough to navigate through the process of acquiring what you presume to be the best insurance you can, sitting down with a broker who'll help you acquire that product. There's way more beyond that. It's being able to effectively advocate for the highest level of utilization of that product, to guarantee that you're going to get the maximum levels of services, care, coverage with that insurance that you have. So there's the process of, how do I get into Medicare? How do I acquire enough coverage with Medicare? But also, how do I effectively use it? And unfortunately, with our healthcare system as it is, it's a matter of being your own advocate or finding someone who can be an advocate for you, fully understanding how the system operates and being prepared to fight to access that level of care that you believe you need. So that's what we're going to talk about. By the end of this presentation, you should be able to understand the basic functions of Medicare coverage, understand the basic functions and procedures for accessing hospital-based services, know the difference between when you're in hospital as an inpatient and in hospital in an observation status, and how those statuses can impact the access and cost of care you receive. Understand the process of transitioning out of acute care and the additional care options that are available to you. And those are important because often the stay in an acute care mode, the hospital stay, is pretty minimal, limited to only a few days. It's the follow-up process that's going to be critical to your outcome. And recognize the role of the patient advocate in assisting individuals in navigating through that healthcare system. To start with just establishing some foundations with Medicare so that you guys have an idea of what normal coverage mode would look like. So anyone that's fully in the Medicare system is going to be enrolled in the two parts of Medicare that represent government's platform. The Part A, hospital care, and Part B, the outpatient or medical care. Now, Part A covers a significant part of the cost associated with being an inpatient, and Part B covers a significant part of the cost associated with the outpatient care. And these two components pretty much have been the foundation of Medicare since it was created. In fact, it's usually referred to as traditional Medicare or original Medicare. And for a while, they were considered to be sufficient to cover the cost of care for most individuals in the Medicare system. But in time, as the cost of healthcare escalated, an essential aspect of Medicare was the reliance on more than just Medicare A and B to cover the deductibles, the co-payments, the co-insurances that Part A and B imposed on individuals. And as a result, they relied on private insurance to cover that. So Part A imposes just by itself a deductible of about $1,500 for the stay in hospital. Now, after that, the first 60 days are covered. And then from day 61 to day 90, the cost sharing is about $389. And then after that, the cost escalate to the point that ultimately the individual is paying full cost for the daily stay. But notice that once you've been assigned the initial deductible, the $1,556, the first 60 days of stay in hospital, acute care, is fully covered just by Medicare Part A. And the transition from acute care, hospital, to rehab, the first 20 days is typically covered by the Medicare system. But because of the accumulating additional cost imposed after that period, and the concern that individuals may not be able to afford the continuous stay, individuals are usually compelled to get something in addition to just the Part A coverage for inpatient. For outpatient, same thing. It's measured a little differently. Part B alone imposes a small deductible initially. Currently, it's $233. And once that deductible's been met, Medicare steps in and covers 80% of the outpatient costs, and the patient is stuck with 20%. But 20% of a exceedingly expensive amount can be preclusive. And thus, again, individuals are compelled to rely on private insurance to round out the coverage in addition to Medicare Part A and Part B. Under the Medicare system, there's 3 categories of insurance. An individual could utilize a Medigap as a supplement to Medicare Part A and Part B, or they could enroll in an HMO or PPO, which is essentially an alternative to relying on Medicare A and B. And in either case, whether they're using a Medigap to supplement basic Medicare or replacing basic Medicare with an HMO or PPO, they're going to also have likely prescription drug coverage, a Part D plan. Now, this is typically the 2 models of coverage that anyone in Medicare would be utilizing. Either they're going to have Medicare Part A and Part B, that represents option 1, and they're going to utilize a supplement, a Medigap, to pay off the portion of costs that Medicare A and B don't fully pick up. They'll have a Part D plan, and if there are other kinds of services that are outside the orbit of the Medicare system, then they'll get additional coverage. In this case, Medicare A and B are primary. Coverage is going to be deemed by facilities that accept Medicare, which is pretty much every facility and every healthcare provider in America. And a Medigap will likely pay the entire balance of what Part A and Part B don't cover, so that an individual has an expectation that whatever the service, whatever the charge, as long as it's under the Medicare umbrella, it's fully paid for. Prescription drug coverage, not quite as good, but because it's a separate product, it allows the patient to go shopping for a superior quality of product. Alternatively, individuals, instead of supplementing Part A and Part B, enroll in A and B, but basically disregard the coverage of A and B by picking up instead an Advantage plan, an HMO or PPO managed care product that replaces reliance on A and B completely. The individual that has a Advantage plan, an HMO or a PPO, is relying exclusively on that Advantage plan to cover the costs of both inpatient or outpatient care. The Advantage plan can include Part D coverage. It can also include non-medical services, but it's going to be less comprehensive, and it's also going to usually impose a network of providers the individual has to go to. And so in Katie's case, she opted for option 2. She was enrolled in A and B, but she wasn't utilizing A and B. She was reliant exclusively on a private insurance company's PPO for coverage. And her expectation was going into hospital for the operation was going to have a copayment of about $250 for the entire stay. However, when the insurance company decided not to cover the second stay, which would have also been a flat copayment of about $250, because it wasn't covered, Jack and Katie were responsible for the entire cost of the stay, which was now more than $20,000. And the first inclination of the hospital was to try to collect as much of it as possible by establishing a payment agreement and not trying to resolve the issue of why the insurance company was denying it. And it took an effort of administrative advocacy to finally get at least one part of the side demanding recovery to relent. This wasn't the normal inclination to say, okay, don't worry about it, or let's work to find out why the insurance is denying. It was, well, can you pay some of it? Can we pay it over a period of time? And for many individuals faced with that challenge of the insurance won't cover it, I don't know, what else can you do? It's often accepting the responsibility and paying this off in increments. Doesn't mean the bill goes away. It just means it's going to take an extended period. And it also means that at some point in time, the hospital, now that you've acknowledged you owe the money and that you're paying it, may decide to throw out the payment agreement and demand full payment. Or if you pass away, may seek to recover from the estate the balance owed. This happens constantly. And this acknowledging a payment agreement also acknowledges your responsibility to pay it down the road, rather than trying to resolve it so that you make the cost go away. So let's go back to the point of entering into the hospital. Now, in Katie's case, this was elective. It was understood ahead of time that she was going in, and there was a model of expectation. But I'm going to change this just a bit and create a situation where, and this is very typical, you're entering the hospital unexpectedly. You have an event that compels you to go into hospital through the emergency room. It's serious, it's unexpected, and unless you've anticipated ahead of time how you're going to deal with this, it often creates, for the individual, for the family of the individual, a crisis moment. So before the crisis moment, you ask yourself, if I have an event that compels me to go into hospital, do I have all of my necessary information available? Where could I put my hands on it? Where are my insurance cards? Where's the information about the medications I'm taking? Where's the information about my treating physicians? Any allergies? Is this in one single place? And where is it? And if I can't relay that information to an EMT, or when I get to the emergency room, who's going to relay that for me? Where's my stuff and how can I do it? And if you are single or widowed, if your kids are far away somewhere else, who's going to be responsible for that? And Is that person who you deem to be responsible accessible, immediate, competent? Are they going to know where that information is? Are they going to be able to relay it effectively? What steps do you take in case not? What's likely the process once you get in there? An expectation of how the care is going to be administered, what the process of navigating through this acute care facility. Most people don't know. Most people are completely unaware. Most people are at the dependency of the hospital to take care of it, which is relying on essentially an individual or an entity that is often your adversary. They don't intend to be. They certainly don't present themselves as such, but in effect, they are not your friend. They're not looking out for your absolute best interest because they're compelled to also look out for their own economic interests and to rely on the insurance to be absolutely positively accessible for doing these things is inherently a risk in itself. So what is my insurance covered? Certainly the expectation it covers a stay in hospital, but how much of it? And how does it cover? And ultimately, how much is it going to cost me? And do I have an expectation that the insurance will follow through with the coverage or deny the claim for whatever reason? And just as important as everything else, what's the next level I'm going to go to in this process? Once I leave the hospital, the acute care facility, where do I go next? Because ultimately, where you go next and the care you receive in that next place is critical to your final outcome. What used to be the norm of going into hospital, the initial acute care facility, and have an expectation that you would be there until you reached full resolution. You're either going out vertically or horizontally, but when you go out, it's at the point where the final level of service has been administered. This is no longer the case. Acute care is often simply the first stop or a short stop, to be sure. And ultimately, where you're going to end up in the next step of your care level is going to be elemental, that level of care that you're getting, and it's going to be essential in terms of the cost you're going to meet. And most individuals simply assume that going into hospital is going to be a transitional process, that it's going to take care of each of the steps necessary. But quite often, almost constantly, that process is a matter of challenge by the patient, the patient's family, and not the facility as much as the entity covering the costs. But usually the facility works hand in hand with the insurance, not with the patient. There's the initial entry into the hospital. Either the family packs the patient into the car. More often, the individual's arriving by ambulance. Once they arrive at the ER, there's going to be a clinical and financial assessment immediately. In fact, it's very likely you're going to be seen by an intake person before you're seen by the ER clinical staff in any level of care. And what they're assessing is your capacity to pay for the stay in the hospital. They're looking to see what insurance you have, and they're looking to see how this insurance is going to cover that stay. If you're admitted, if it's decided that the severity of the situation and the fact you have insurance, and believe me, do not assume that if you are underinsured or have no insurance, that facility is going to keep you because your condition is severe. They're going to strive to provide the minimal amount of care, considering they're not going to be paid significantly, and be able to discharge you without liability. So once they've determined you have insurance and it's sufficient, once they've determined the severity of the condition requires admission, the first step is to get you to complete the admission documents. Now, be careful. One of the admission documents is whoever is signing it is accepting full responsibility for full payment in case the insurance denies the services. It's not just going into hospital. Whenever you go into a doctor's office, whenever you go in for outpatient treatment of some kind, you're signing one of your documents each time you navigate through the healthcare provided, accepting the full responsibility that in case your insurance denies coverage for that service, for that procedure, you've agreed to accept the entire cost responsibility. And if you don't sign the document, you don't get the service. If you don't sign the document, you don't get admitted. And it's not just for medical care. This also applies when individuals are admitted into long-term care facilities, nursing homes. The family member that signs the papers to move grandma into a nursing home also unwittingly acknowledges that in case there's a problem with the facility being compensated to the fullest level that they believe is essential, they can come after the individual creating the documents. And in Pennsylvania, that nursing home facility is actually empowered to go after family members, even if the family member didn't sign the document. So understanding that well after the service is provided, if insurance or if benefit programs fail to adequately pay for the cost of those services, the institution is empowered to go after individuals to make good on the payment, even individuals not directly associated with the individual receiving the care, as long as it's a family member. And honestly, as long as that family member has deep enough pockets that can be pursued. Once the admission documents are completed, a case manager is assigned. Now, that case manager is the patient's point of contact with hospital administration. Their job is supposed to be the liaison between the patient and the administrative system, help them navigate through the process. But honestly, the case manager's job is to transition the patient out of the hospital as quickly and smoothly as possible. Minimize the length of stay, minimize the utilization of services and the cost of services to the facility. Not just because the facility wants to be as efficient and as minimal costly as possible, but because the insurance entity that is responsible for paying it wants to minimize the cost impact to them. So the case manager is really the liaison between the patient and something called the Hospital Utilization Review Committee, or Hospital Utilization Team. That team, made up of physicians, but also administrators, and to be sure, a representative of the insurance company, is reviewing on a very regular basis the patient's care regimen in this circumstance. They're determining the length of stay. They're determining the degree of services, the amount, the level. And it's very much driven if the individual is covered by private insurance like that HMO or PPO, by the person representing the insurance company's interests. And if it so happens that the insurance company owns the healthcare system, or if the healthcare system also operates its own insurance, then in either case, or even if it's completely unrelated, the system versus the provider, it's very likely the insurance company that's driving the accessibility of care, the length, the degree, and the quality, to minimize the cost to the insurance, and for the facility acquiescing to this because they want to get paid. And so often, your level of care, your quality of care, your duration of care is not dictated by your physicians, by your healthcare professionals saying this is what should be done. If that was the case, very likely Katie would have stayed in the hospital an extra day or two to monitor her extreme conditions, and most likely receive the antibiotics and the intervention necessary without putting her life at risk. But because the insurance instructed the facility to discharge her because a computer algorithm said, based on the circumstances of the care she was in for, based on her previous circumstances, based on a number of factors, it was essential to have her discharged. And regardless of the intervening factors, once this decision was made, it was difficult to impossible to change. And because no one was at that point aggressively advocating on Katie's behalf as a patient in need of care rather than an economic object, the discharge went through. When you're in hospital, one of the most important things you should be asking yourself, is this stay an inpatient stay or an observation stay? Most individuals haven't the foggiest idea that these concepts exist, or at least the concept of observation exists. Most individuals, most lay individuals, assume that being in hospital means you must be an inpatient, that the admission defines the inpatient status. Absolutely not. And the difference between being in a hospital as an inpatient or being in a hospital in an observation status makes a huge difference in the duration, in the level of care, but most important, in how that level of care is paid for. Now, observation status it's just a status. It's a terminology. It was created relatively recently. This is not something that existed going back to the ancient days of hospital care. It's a definition for short-term in-hospital stays where the stay is to monitor or diagnose the patient's condition, determine whether the patient should actually be admitted to a higher level of care. These stays are typically limited in duration, typically less than 48 hours, but not always. I have a number of situations that I've represented that exceeded 48 hours. It's simply a factor. And one's not going to easily know whether their being in hospital is under the inpatient or the observation status. So how do you know? Well, initially you have to ask, and you should ask. You should ask a lot, because that status can change while you're in. You may enter in an inpatient status, not typically, but in the past it was typical. And then that status changed while you were in, and not just changed from that point, but changed retroactively back to the instant that you went into the facility. So why is the status important from the standpoint of the facility and the standpoint of the patient? Well, if the Medicare system determines, or the private insurance system determines, that the person was admitted to the hospital incorrectly. They were defined as inpatient, and this was incorrect. Then the hospital typically receives no reimbursement at all for the patient's care. It's essentially being punished for making an incorrect determination. Why is that so important? Because the overall cost of reimbursement to a hospital for an inpatient, which bundles all of the services together into a single reimbursement amount, and typically larger than treating each individual level of care administered while in the hospital, is a greater economic burden to the insurer, whether that insurer is private insurance or Medicare. And the threat that the individual facility could lose all reimbursement, could have to eat the entire cost. So to avoid losing that total reimbursement, hospitals err on the side of defining the patient as in observation. In fact, it's overused status. They're willing to accept a smaller reimbursement from Medicare or from private insurance for a guaranteed reimbursement amount. And so very likely, if you're going into hospital, certainly for a relatively short period, but honestly, most stays now in hospital are relatively short, measured in a few days. And if the service does not involve an invasive process, an operation, it's very, very likely that your stay is going to be characterized as observation and not truly inpatient. There's another reason. If an individual enters a hospital as an inpatient, is discharged, think of Katie now, and within less than 30 days of the discharge returns, then that individual creates a reported instance to the insurance company or to the Medicare system. If that hospital realizes too many turnarounds, patient discharged and then returning within 30 days to that facility, or in the Medicare system to any facility, enough of those black marks within a benefit year means that that facility or that healthcare system is reimbursed by Medicare at a lesser amount for the upcoming year. And plus they have the stigma of Medicare announcing that this healthcare system has an unacceptable readmission rate, that it is likely, the odds are greater, that individuals going into these hospitals under the system, or that hospital in particular, are going to be returning within a relatively short period for a incomplete procedure, post-operative infections, all sorts of things. And so by categorizing the patient as not really being inpatient in the first instance, or by denying their ability to return at all, they not only avoid the cost, but they avoid the stigma of a readmission problem, and they avoid being penalized later by the Medicare system. And so the big reason that the hospital waived the pursuit of payment in the case of Katie and still acquiesced to, they really didn't admit Katie after all because it was denied by the insurance. And the record doesn't go to Medicare. It doesn't create a red flag of a readmission, and it minimizes the impact of the penalty. It's actually more economically beneficial for the hospital to say, here, you're comped for your second stay, rather than get into a fight, which brings the attention to the Medicare system, that Katie was truly readmitted, because that second entry was a readmission initially in an inpatient status. And that in itself was setting off a red flag that compelled the insurance company to deny admission and challenge the veracity of the second time in. So it's not just the cost, but it's also the impact from an administrative standpoint and from navigating through the Medicare system that often compels insurance companies and healthcare facilities to challenge the utilization of healthcare services. Now, there is something called the 2 midnight rule. Centers for Medicare and Medicaid Services, the regulating body of the Medicare system, imposes a guideline that the inpatient status is appropriate when the patient requires a stay that's longer than 2 midnights. So if I go in later in the evening, 10 o'clock, 11 o'clock p.m., and I cross the midnight threshold, that's my first midnight. If I'm in the facility long enough to have one more midnight, so it doesn't necessarily absolutely mean 48 hours, simply I've been in facility for a 2 midnight period, then it's presumed that this would generate an inpatient status. But that's not absolute. It's presumed, but it's only a guideline. And CMS and private insurance providers have failed to aggressively apply those parameters to individual cases. It is more likely that a hospital is going to be challenged if they assign an inpatient status and have to argue and justify why the inpatient status, why the stay merited, and that it exceeded the 2 midnight rule, and not just that it exceeded 2 midnights, but the other factors were indicating. There was an invasive process. There was extensive procedures carried out. And quite honestly, for healthcare systems, especially if they're relying on a relationship with the private insurance that is also part of that healthcare system, it's easier to simply acquiesce to an observation status and not risk the challenge. And so very often, stays in excess of 2 midnights are still categorized as observation. It's baked into the system now. Most likely, you're looking at an observation status. For the patient, if you're assigned an inpatient status, then your expectation is the care is going to be covered under Medicare Part A, if you're relying on Medicare A and B as your primary, or if you have an HMO or PPO, it's going to be under the cost sharing relegated to inpatient stays. And that means that usually the cost of being in hospital as an inpatient is far less expensive to the patient, that the insurer eats a larger part of the cost and passes on far less to the individual. On the other hand, if the patient is categorized in observation status, then it's considered an outpatient. You're not actually in the hospital in the sense that you are, even though you're staying there, even though you're in a bed, in a gown, with a wristband, you're not in the hospital. You're in outpatient mode for all of the services, all of the care. And if you're relying on Medicare A and B directly, then that's under Medicare Part B. Or if you're relying on an HMO or PPO, then it's not measured as a single event with a bundled cost reimbursed. Each of the services you receive are treated separately with an imposed cost sharing. Individuals that are in observation status have the expectation, or should have the expectation, that all of the services they received while they're in the facility, but not really in the facility, All the diagnostics, the lab work, the examinations, the injections, the infusions, the therapies, everything are going to be individually billed with an individual copayment requirement. And if they're in observation status, any medications they receive during their hospital stay are not going to be part of the bundle of care. They're going to be billed separately under Part D coverage. And that means a copayment obligation to the patient. And if some of the medication that the patient is taking during hospital aren't covered by their Part D at all, the patient's going to be required to pay full cost. And the patient's not going to know this, not fully understand this, until they've left the facility, received the bill, this huge page after page itemized bill of these costs that includes each service and each medication and each cost sharing that goes with it. In addition, normally, to be able to transition from an acute care facility, a hospital, to the next step, like a rehab facility, it requires that you be inpatient for at least 3 days. But if you're in observation, you're not inpatient. Therefore, you have not accumulated the 3 days. Thus, the ability to transition smoothly to the next step is often delayed or impeded by that status of care. If your coverage is Medicare Part A and Part B, and you have a Medigap, and the impact, the cost impact, is pretty minimal. In fact, you may find there's no impact. It doesn't matter what your categorization is going to be. However, if you have an HMO or a PPO, Katie's case, a PPO, then you may find that the definition of your status in observation has a significant impact. Even if the insurance company agrees to cover that stay in hospital, if you're recognized in observation, the cost sharing could be significant. And some HMOs and PPOs might build in some kind of mitigator to reduce the cost so it's not literally every single service, but don't count on it. Most of the products that represent private insurance, HMOs and PPOs, impose a significantly larger cost sharing for the patient if they're in observation versus if they're categorized in an inpatient status, and thus the motivation on the part of the insurance company to weigh in with the facility, and especially if that facility happens to be owned by the insurance or the insurance happens to have a disproportionate say in the process, very, very likely the definitional outcome is going to be observation, and the economic income is going to be disproportionate to the patient. I'll give you a couple examples. This is a real patient. It's not Katie and Jack, but it's an individual who went in to hospital and with coverage of Medicare Part A and Part B and a Medigap. That patient generated a cost in services. And it's about $24,000. Now, if it was just Part A alone, the patient would have been responsible for the initial deductible, $1,556. And because the stay was certainly less than 60 days, that was the entire cost that the patient would bear out. And Medicare, remember, Medicare Part A and Part B is the primary coverage, so Medicare would have eaten the rest, a bit more than $22,000. If the facility characterized that same individual instead of inpatient as observation, which in fact is what they did, the cost was reduced from $24,000 to only $15,400. The cost to the Medicare system, same services, same administration of those services. Medicare would have only been on the hook for, because these were itemized separately, to 80% of each itemized amount, and the patient would have been on the hook for 20%, the balance. So 15,470 for the same services. Medicare responsible for 80% of that, a bit more than 12,000, and the patient responsible for 20%, about $3,100. Because these were itemized services, also the oral medications the patient was taking, which retailed for about $1,200. The patient's copay was $63. The patient had relatively good Part D coverage. But notice, if that individual didn't have a Medigap, they would have been responsible for a bit more than $3,000, including their 20% and the cost of their medications. But because the individual had a Medigap along with their Part D coverage, the Medigap paid the entire cost. And it would have paid the entire cost whether it was Part A inpatient, they would have paid the $1,556, or outpatient, the Medigap would have paid the $3,094. In either case, the patient's total bill would have been completely covered by a combination of Medicare Part A or Part D and the Medigap. The only amount this patient was billed for was $63, the patient's copayment share for the oral medications that they received while they were inpatient, or rather while they were admitted into the hospital. So in either case, an individual with Medicare A and B and a Medigap and a reasonably good Part D coverage is somewhat protected regardless of the status of the stay. It's simply mitigating the cost down for the sake of the insuring entity, in this case Medicare. But change that. Make the individual now covered by an HMO or a PPO. So I took that same scenario, and if that individual had been covered by a fairly common and not even the cheapest bargain basement HMO or PPO available, but in this case, a product that represented reasonably good coverage, kind of one of the mid-range HMO products. That patient's copayment, if they had been recognized as inpatient, would have been only $275 for the entire stay, regardless of the length of the stay, regardless of the services administered. And the individual would have expected, because they're in a facility, they're in a bed, they're in a patient's gown, all the trappings that point to be inpatient. That individual would have assumed. They wouldn't have even bothered to ask, and they would have assumed that the cost was going to be simply $275 for the entire stay. However, because ultimately there was a likelihood, because the stay was relatively short, it's actually a bit more than 2 midnights, so it challenged the guideline. Not much more, but still more, which still, if you use the guidelines as an absolute rule, would have meant the individual was inpatient, but not, they were observation. And because there was compelling reason for, in this case, the UPMC insurer working with the UPMC facility that we would put this person, that the observation status would have imposed cost sharing of more than $3,600 for the same procedure. And now there is no backup. This is the HMO's cost sharing. There's no other insurance that's going to pick up any part of the balance of that $3,600. This is the cumulative copayment for the ER visit, because The ER visit, if it's an inpatient, is rolled into the total cost. But now this person is outpatient, so the ER visit is counted. The stay at the hospital has a count called room and board. The being in the bed, in the room, has a cost, which is co-paid to the patient. All of the services that the patient receives, the blood work, the labs, the x-rays, the high-end diagnostics, the examinations by the specialists, the PCPs, the therapies received, and the oral medications. Collectively, the copayments responsible for that well exceed what the patient had expected they were going to pay. In the case of individuals going into facility with an HMO or a PPO, regardless of the company, regardless of the level of care that the HMO or PPO promises, there is a pretty absolute expectation that the difference in cost to the patient, whether the patient is inpatient or observation, is significant. Now, you may not experience that. You may sail through your process of coverage for your entire life without facing that circumstance, but it is more likely for stays that you're incurring, especially minimal stays, especially for non-invasive processes, that you're going to be presented with a series of bills, and those bills are going to far exceed what your expectation was. And who controls? Who decides? And I think I've indicated pretty comprehensively that you have no say in the matter. There's guidelines that dictate it, but really the initial determination is made by the hospital, by the physicians that initiate contact, usually the emergency room physicians, determine whether you're being admitted as an inpatient or observation. But it's not ultimately the physician's final call. Once the case manager has been assigned, one of the first things the case manager does is review the admission to determine, among other things, whether that admission status was correct or not from the standpoint not of what the physician thought was necessary, but with what the hospital thinks is necessary to work within the expectation of being paid by the insurer. The case manager brings it to the attention of the hospital utilization team to determine whether this admission status should stay or be changed. And very, very often, if it starts as an inpatient, it gets flipped to an observation, at least for the time being, at least until factors make it imperative that an inpatient, and that is less than 20% of the time in cases of admission in this region. It is most likely that in a non-invasive process, a process that doesn't involve an actual operation, that you are going to be categorized as observation, and the cost of that is going to be larger. And that is going to be dictated not by the physician that admits you, not even by the physicians that continue your care. They could care less. It's going to be determined by hospital administration, and even that is going to be determined really by the insurance entity that's going to dictate how the hospital is going to be paid for the care you receive. And as long as the status, whatever that status is made prior to your being discharged, as long as they haven't submitted a claim to Medicare or private insurance, and as long as the physicians concur, and they're going to concur, then the decision that documents the patient's status can be changed up until the instant of discharge. And I've had cases where the patient who asked aggressively at the beginning assumed that they would stay in an inpatient mode, had it changed on them in the first review committee's meeting, and it retroed back to the instant that individual came into the emergency room. And so a person assuming they were looking at a much less amount, found that when they finally received the bill for thousands of dollars, it was based on a recharacterization of the individual in observation status. So when you enter the hospital, when you're assigned an individual to look after your navigation through the process, a big part of that case manager's responsibility is to make sure they're guarding against the imposition of excessive cost to the hospital, but even more importantly, excessive cost to the insuring entity. They are more a representative of the insurance interest and the hospital facility's interest than they are of your interest. And so individuals often find they're being compelled to make decisions based on limited choice options provided by the administration of the facility. Now, they are supposed to be notified, and they are, of what their status is ultimately. If a patient is ultimately in observation status for more than a 24-hour period, then within the first day and a half, the first 36 hours of their care, they have to receive a notification, a written notification, and orally presented to them, explaining that they're in observation status. It's referred to as the Medicare Outpatient Observation Notice, the MOON notice. And whether the individual is covered under Medicare primarily or a HMO or PPO, the patient has to be notified. They have to be notified of what their status is. They have to be notified of what the economic impact of that is. And they have to sign that notice in the presence of the hospital representative. And if they refuse to sign, then the hospital staff present has to sign for them, making a notation that the patient refused to sign, but was provided with that information. So, and even if they fully understand, even if they acquiesce, there's not much they can do about it. This individual has now been in the facility for at least a 24-hour period. Most likely, they're not going to know about it for a few hours more, possibly even another 12 hours more. And at that point, they're in the midst of being taken care of. They're hooked up to IVs. They're hooked up to equipment. They're in the midst of being taken care of. And to be told, well, let me warn you, you're in a status that's going to likely generate a much greater cost. And they're not even really going to tell them it's a much greater cost. They're not going to give them the dollar amount. They're simply going to say, and you're responsible for the copays related to this. And most people aren't going to understand that till they get the bill, till after they've been discharged. And even if they fully understood what the impact is, what are they going to do about it? Appeal? Not till after the discharge. And the success rate of appeals challenging observation versus inpatient status is significantly in favor of the institution or the insurance company, not in favor of the patient. It's about a 7-3 ratio, about 70% of the time in favor of the facility and only about 30%. And in those cases, there has to be an egregious error in the process and usually some demonstration that the MOON notice wasn't provided. So what about coming out of acute care? Where's the next step? So the going in, the status definition, the impact of that definition on how much you're going to pay, that's just the start. Because as I said before, a critical aspect of the total care you're going to receive comes not at the acute care point, but at the kind of care facilities or care modes that you receive after the discharge from the acute care. So any process of inpatient or observation carries with it the discharge planning. Where do I go after this acute care, regardless of my status? What do I need? And what are my options? And here again, the problem is relying on the hospital's administrative staff, the case manager, your liaison between you and the hospital's administration, is not inherent to your interests. It's inherent to the interest of moving you to the next place, effectively getting you out of their hospital to wherever. And from the case manager's personal standpoint, considering that he or she has a caseload far in excess of what they're supposed to have because the staffing of the case management is usually pruned down for cost savings reasons, they're compelled to move this as quickly as possible because they've got their own manager looking over their shoulder saying, we need to get this person committed to the next place they're going to, get them out. And so very shortly after you show up in the hospital, again, regardless of your status, your case manager is saying, here's our projected length of time. You're going to be discharged probably on this day. We're going to send you home, or we're going to send you to some other place, depending on the severity of the care you need, depending on the circumstances that you have as a home environment. And so if the individual is going to be moved somewhere other than home, what's that going to look like? And what options do they have? Most of the time, if the individual is not savvy as to what the options are and the quality of those options, they're relying absolutely on the case manager to make the choice for them. And the case manager is usually going to give them a list of selections, places that they would go to next, or if they're going home, home service providers. What's the criteria of selection? They're available. That's the criteria of selection. The rehabilitative facility they go to after acute care is there's a bed available. Here's 4 places that have beds available. There you go. Are they good? I don't care. There's a bed available. Take your pick or pick another one, but now the burden's on you to do the shopping. The quality, oh, they're all fine. Really? So there's no qualitative assignment. There's no assistance in understanding the process in terms of the specifics. They're simply, here's some choices, pick one you want because you're being discharged one way or the other. Or if you're going home, here's a list of home care providers, pick one, and I'll help you connect with them. I'll help you in the process of getting you out because my job essentially is to minimize your stay and minimize your economic impact. So usually an individual is given 2 possibilities. Ideally, we want to send you home. If that's not realistic under the circumstances, then we're going to send you to a skilled nursing facility, a rehab facility. That's pretty much the 2 choices you get, responsible to the case manager. But that's not the case. So start with the idea that the typical next step, if you're not going home, is a skilled nursing facility, abbreviated to SNF. Now understand that if you were in a hospital, theoretically, you could be there indefinitely and Medicare or private insurance would pay for it. Now, ultimately, there may be cost sharing, but if you have a Medicare and a Medigap, your stay could be theoretically indefinite. And as long as you stayed, it would be covered by Medicare or the private insurance. Once you go to a skilled nursing facility, a rehab facility, a limit is now imposed. Even if your insurance is willing to cover the stay to the maximum number of days, the maximum number of days you have in skilled nursing is 100. That's it. A bit more than 3 months. which is one of the reasons that insurance companies are so compelling to get the person out of the acute care as quickly as possible. First, the cost of acute care, whether inpatient or outpatient, is significantly more than being in a rehab unit. More importantly, once they're out of hospital, a timeline starts, a 100-day timeline. No matter what compels the individual to stay in that skilled nursing facility, the 100th day is the last day covered by the insurance. Day 101 is presumed to be by both Medicare or private insurance as flipping to a personal care-centric need. And thus, Medicare, Part A and Part B, or private insurance HMOs and PPOs are finished. And the responsibility of paying that comes out of the pocket of the individual, the individual's family. Now, an alternative to going into a skilled nursing facility, a typical rehab facility with its 100-day limitation, is going into something like a hospital-like setting. And there's two examples of that. There's the rehabilitative hospital, which can look like a skilled nursing facility, but it's not. It is still a form of acute care, which means there is an unlimited duration. It's emphasizing rehabilitation, kind of like the skilled nursing facility, but it is far more significant in the level of care, in the patient to professional ratio level, in the equipment available. An alternative to that even is going into a long-term acute care facility, an LTAC. Again, it's a hospital. It is a hospital designed for individuals whose circumstances are so severe, so acute, that to send them to rehab would be out of the question. They're incapable of engaging in a rehab, and they're incapable of being sent home under the circumstances. The level of care they're in need of cannot be administered in a home setting. Now, just because you would like to be in a rehab hospital or long-term acute care facility doesn't mean you get it. And this usually means a hard-fought process, not so much with the facility as in the acute care or the next, but with the insurance that's paying for it. And understanding when you are eligible to go to rehab hospital or eligible for an LTAC, and you have the likelihood of successfully negotiating and arguing and advocating on your own behalf, is pretty limited for most individuals. And absolutely, it is unlikely that a case manager is going to explain, look, in addition to your typical rehab facility, the skilled nursing facility, here's some other options. And here's some other places that fulfill those options. That's on you. That's on your shopping. That's on your research. That's on your commitment to find an alternative. And the individuals are usually confronted with a limited time in which to make the decision. Either make it or we're going to make it for you. One way or the other, you're being discharged. And so going into an acute care facility has a time limit and a decision limit. And unless you are aware of how this works or can find a resource that will represent your interests and explain the differences and show you how to acquire these alternatives, you're most likely going to end up either going home or going into a typical skilled nursing facility with its limitations. The quality of care, the level of care is significantly better, and the length of care is significantly longer in rehab hospital or long-term acute care facilities than a skilled nursing facility. But accessing it takes a far greater effort and usually requires someone representing your interests and not the case manager. The possibility of not going into any next facility uh, but ultimately going home. And if that's the case, if it is likely, and honestly, patients would much rather be at home if they can do it, but sometimes it's not practical. But when it is practical, when it is capable, uh, be aware that at home, individual could be entitled to uh, outpatient services, the kind of services that one would go from home to a outpatient facility. If that's not possible, but there's not the necessity to stay in a rehabilitative facility, those home care services could be brought to the individual. Um, and not just home care services, health care services, but also personal care services. But the thing is, if you're in facility, even a skilled nursing facility, you're there for a 24-hour period. You're in that facility, even though you may not be considered inpatient, but you're in that facility. In the case of home care services, either health care or personal care, those services are far more limited. You're talking about a few hours at most a day, and not necessarily every day of the week for these services being delivered. And then the question becomes, especially for personal care, how are you going to fill in the gaps when the home care providers aren't there to provide you with health care, therapy, or just basic personal care services? And if you really can't return home, if you've exhausted the skilled nursing facility capability or the alternatives, if going home because of your circumstances, because there's no one there to take care of you, because you're unable now to take care of yourself, or you were already having difficulty taking care of yourself, may very well mean that you're never returning home, that your next stop from the acute care or the rehabilitative facilities is to either a personal care facility or a long-term care facility. And in both of those cases, the cost is borne out exclusively by the patient. Medicare, private HMOs, and PPOs will not pay a nickel towards the cost related to the personal care facility or the long-term care. If in addition it requires medical care services, certainly that would be covered under Medicare or private insurance, but not the being in the facilities. And this is where the economic devastation occurs to the families. And remember what I said, the transition from some type of rehab or acute care to a personal care or long-term care facility oftentimes imposes an economic burden, not just to the patient, but to the patient's family. And if the patient's family doesn't fully understand that they could be fully on the hook for responsibility, they may very well be looking at economics not even measured in the thousands, but the tens or even hundreds of thousands of dollars to make up for the cost of care for an extended period of time in personal or long-term care. And most individuals are not aware of the issues, the problems, the outcomes. Because here again, the case management, the intake people at the long-term care facilities or personal care are not as efficient as they should be. And again, there is no one that's necessarily representing the interest of the patient or the patient's family over the interest of the facility of collecting their money and getting paid. Finally, the possibility when patient and the patient's family acknowledge that their life expectancy is limited, uh, that the capacity of care to sustain their life has reached its final limit. And the individual has embraced the idea that within a short period of time, they're going to pass away. An alternative to rehabilitative care with the expectation of getting you recovered, recovering the level of capability, instead acquiescing to the idea that this is simply keeping you in a stasis condition, until death overcomes you. This is hospice care. Now, you're not sent necessarily to a hospice facility. Hospice care is often delivered to your home. It is likely more extensive in hours and levels of care, but it's for a presumed limited duration of time. The expectation is you're going to be dying soon, and that you've accepted that, and you've also accepted the kinds of care are going to be limited. The kinds of services with the expectation of recovery are now minimized. This is about making your last days, weeks, most likely no more than weeks, um, as comfortable, uh, as expedient as possible. And for some people, this works quite well. But keep in mind, even though the amount of care in terms of the number of hours may be lengthened, and the quality of care certainly can be quite high, but the kinds of care are now limited. And families misunderstand that and misunderstand that this is just a way to get more care, more hours, more extended days without having to go into a long-term care nursing home. Yeah, but it means essentially passing on most of the recuperative care services, passing on the coverage of certain medications and procedures, and the expectation that the individual is going to pass away. And if that is understood and if that works, this can be an effective option, but it has to be thought out and it has to be well explained. And often it isn't, to the consternation of the family and the confusion and frustration that happens after the services. And it also is, hospice is not going to cover things like the individual falls out of bed, wounds their body in some way, and has to go back into emergency room. That requires a shifting from hospice care back to traditional health care. And once they've been released, shifting back to hospice. And often by not doing that administrative shifting, they find that once they've been taken to the emergency room for an accident, for something that isn't presumed to be under hospice, they're billed for the full cost because hospice says, no, this was a recuperative or a rehabilitative process. What the person banged their head, they were bleeding from their forehead, but we don't cover that. Sorry about that. And again, understanding the expectations, the parameters of hospice care are essential. And knowing if you need to flip from hospice to a more standard level of care and not giving up the standard of care. Often people are said, well, you're going to be on hospice. Why do you need the other insurance? Because an event may occur in the process of you passing away that is not covered under hospice, and you may need to shift back to a more traditional mode of care just for that emergent situation that most people don't think through. So there's going to be, in accessing this next step, certainly the clinical criteria. What do I need? And the financial criteria from the standpoint of what can I afford to pay? What is the insurance company willing to pay? But also personal preference. It may be individuals saying, look, I want to go home. I know this is probably not the best solution, but I really want to go home. Or I accept the fact that I'm going to pass away. Versus the person that says, no, damn it, I want to fight. I want to fight to stay alive, to have the maximum amount of care for as long as I can. And this is a personal preference. But unfortunately, it's often dictated by the economics of other factors without an effective advocacy on behalf of that individual's interest. And often the options made available to the individual and the individual's family don't take into consideration the full scope of the individual and the family's preference. And so the reliance on someone to represent the interest of the individual and the family, someone that's not associated with the care facility, someone that's not associated with the insurance company, certainly, or the Medicare system, someone that is responsible in a fiduciary way exclusively to their patient. And that's the role of the patient advocate. They're not going to get a patient advocate, regardless of what the hospital says, or the skilled nursing facility, or the long-term care facility. Those are case managers. They are not patient advocates. They are not advocating exclusively for the patient. If this is something the individual wants, they have to seek out this patient advocate, and absolutely well before the acute event that sends them into hospital, and then the sequential steps thereafter. This is as critical as establishing relationships with your accountant, your lawyer, your financial advisor. The patient advocate is a professional entity that encompasses the skills of legal, healthcare, and social work. The patient advocate could be an attorney. Most likely, the patient advocate is going to be someone that is steeped in the experience of the healthcare system. Often, these are individuals that worked for hospitals at a certain point in time. They could be nurses. They could be healthcare administrators. They could be someone that understands how the system works intricately after years of working within the system. Or they could be part of a team of professionals. A good, comprehensive elder law firm is going to have, as part of their staff, an expert patient advocate. And this is an additional service that the clients of this law firm can seek out. There are private patient advocacy entities that are not necessarily affiliated with a law firm. And it's inherent, if you see the value of establishing that relationship, like any other kind of professional service, to shop for criteria of what's going to represent a good patient advocate. So understanding and getting the vibe from that individual you're talking to be your advocate, understanding that they're representing your interests, not the provider or the insurance, and that they have the capability to educate and counsel you and advocate on your behalf. They're going to make sure you fully understand what your options are and all of the options and what the outcomes are. And they're going to assist you in navigating through those systems to access and utilize the insurance if you haven't selected it yet, if you have a patient advocate before you enter Medicare, to help make sure you're selecting insurance based on what you want is the maximum outcome, assisting you in your admission into facilities and the discharge from those facilities and the transition through that process. The patient advocate is going to be there at the beginning and at the end. The patient advocate can literally represent you when talking to case management, hospital administration, billing procedures. They will be responsible for doing the paperwork. They will be responsible for saying, I represent this patient's interest. I am empowered to represent this patient's interest by the relationship, the formal legal relationship that we've established. And when services are denied, I have the capacity to assist or represent this patient in challenging the denial process and carrying it through the full steps of appeal. But a good patient advocate is also going to present to the patient the realistic expectations. For the individual who wants the maximum level of care in all instances, a good patient advocate is going to tell them when they're likely to succeed and when they're likely to fail, and what the cost of that fight is going to look like. Most people do not have patient advocates. Most people don't understand the importance of the patient advocate. And that's unfortunate. Because if this were a perfect healthcare system, if this were a perfect world, then the institutions themselves would be responsible. The government would provide an advocacy service, but it doesn't. And the facilities are not looking out for your interest as much as they're looking out for their own interest. And thus, you either become adept at advocating on your own behalf, not likely under the circumstances, or you seek out individuals that represent a quality level of that advocacy. Any questions?
All right, Bill. Yeah, so what I'm gonna go ahead and do is I do have a couple of questions that were sent, and then I'm gonna go ahead and just unmute the folks that are here in case they'd like to ask anything directly to you. But the first question that I have here is regarding the guidance for the hospitals and what they call inpatient and observation. Are there any laws or at the state or federal level that mandate at least a basic guidance for what a hospital can choose to identify as inpatient versus observation?
Sure. And I'm using, let me back up. The Moon Notice is dictated. It's a federal law, and any institution that accepts federal funding has an obligation of notifying what the status is. But in terms of defining what the status is, the 2 midnight rule. And again, it's a guideline. It is not an absolute rule of once you cross the second midnight threshold, absolutely that individual is now an inpatient. And prior to that, they're going to be absolutely observation. Guideline is the emphasis. Other things that are to be considered is the extent of care received, the inclusion of an invasive process, a operation, uh, all the indications of the care provided are of a diagnostic nature. So invasive increases the likelihood of defining it as inpatient. Diagnostically top-heavy services is a strong indication you're going to be in observation. But these are all guidelines. And remember, the likely possibility is going to be when in doubt, the hospital facility says, look, we don't want to be challenged. We don't want to run the risk of not being reimbursed at all by making the wrong call. There is a likelihood of a challenge if we call this person an inpatient, and we better be able to support this for our own well-being. But you know what? Nobody challenges from an insurance standpoint, Medicare or private insurance, if we call them observation. We know it's going to run the risk of maybe being appealed by the patient. But you know what? Less than 10% of individuals categorized ever appeal that categorization. It's too much trouble. It's too much of a problem. The outcome of that appeal is too long, too problematic, and the need to pay an attorney to represent you through the process generates a strong likelihood that you're not going to appeal, even if you know, thanks to the 2 midnight rule, that you have some standing, or thanks to the Moon notification that you know exactly you're in observation. And the facilities know this, and the insurance companies know this. And so this is why from 2011, there was a disproportionate rise in the number of statuses defined as observation in terms of individuals in acute care facilities versus individuals that are recognized as inpatient. So yeah, there's guidelines, but the likelihood, unless you are there for a truly extended period of time, which is not likely, and you're undergoing services that are more invasive than diagnostic, unless that's the case, you can almost bet you're going to be considered in observation. And again, how do you know? Keep asking. Keep asking until you've crossed the threshold of uh, the moon requirement, which says once you're there in facility 24 hours, you have to be told what your standing is. And as I said, expect a strong likelihood that what you're going to be told is, oh, you're in observation. And then what do you do? Well, damn it, I want out of this place. Not likely. It simply means you're going to be faced with, at some point down the road, going through an extensive appeal process or just acquiescing and accepting it. What's the next question?
The next question is sort of a follow-up to the moon notice. It is you had mentioned that, in the midst of all of the procedures and so forth that you're going through, and you're sort of given this notice that a lot of patients don't necessarily understand or pay attention to it, and that they do have to sign it, or that the hospital staff will sign it. Do they have to sign it at the time of presentation, or do they have until their discharge, for example,
Oh
to
no, they're
sign
not.
that
They do
notice?
not have till they're discharged. This is pretty much, if it's like, can I sign it a little bit later? I got to take a poop and just, okay, I'll be back. But the I'll be back has its limits.
Mhm.
Um, this is not, I'll just keep stretching this out and stretching this out. No, I'm going to tell you what your status is. I'm going to give you a cursory review of what the impact of it is. And here, I need you to sign this. Um, can you come back later? Can I just read over this? Sure. I'll be back in about 15 minutes. I'm still reading. I'll be back in a few more minutes. I'm going to sign it in your presence if you don't sign it. I have never seen any institutions, don't worry about it. We got a few days. Her job is to get this signed and get it in your file. And if you don't do it, she or he's going to do it for you. She's got other things she has to get on with, and keeping this dangling and answering to her manager, how come? It's like, whoa, he just didn't want to sign it. Go back and sign it in his presence, and let's move on with this. We've got other things to do. Next question.
Okay. This is the last one I have in writing, and then I'm going to go ahead and unmute everybody here, or at least give them the option to unmute themselves if they'd like to ask anything following this last question that I have. But that is regarding the patient advocate. So you had said that most people do not have one, and so forth. Where would you recommend, or can you recommend, where should people look for such a person?
Well, uh, there's two ways you're going to find a patient advocate. One is a independent patient advocate provider, a business, a concern that says this is what we do. We are patient advocates. Be careful. It is as difficult to find a good patient advocate as it is to find a good car mechanic, uh, or a good um, heating and cooling repair service, or a good landscaper. Um, Word of mouth, uh, research. But here's another way. If you have an attorney, particularly an elder law attorney, and I don't mean some guy that says, yeah, I'll do your wills and your powers of attorney. That does not necessarily make them an elder law. Oh, they'll call themselves whatever they call them. What you want, if you're looking to combine this with patient advocacy, uh, is a certified elder law attorney, a CELA, CELA, certified elder law attorney, means that the exclusiveness of what they do, they don't do DUIs, they don't do basic drafting of other kinds of documents, they don't do slip and falls, they don't help you with your divorce. All they do And they're certified because they put in not just hours, but hundreds, even thousands of hours in pursuit of this before they're recognized as a certified elder law. A good way to know is the firm focused and competent in terms of elder law. Ask, how many CELAs do you have? None. You might want to be concerned about the extent of the level of care. Now, not all CELAs have as part of their practice staff patient advocates, but it is more likely you're going to have a patient advocate at a CELA firm. And it is likely that person is going to be a permanent fixture of that firm's staff. They're not going to be a marginal associate. Their job on a 9 to 5, 9 to 5, you wish, a regular interval of the workday, the 40 plus hours a week, is to be the advocate for the people that are represented by the firm. Now, it could be done as a informal relationship that in case there's a problem or question, you could reach out and talk to the patient advocate. The firm's social worker is often another terminology, but you could also create a more specific, a more permanent relationship. So that requires step one, sitting down with the social worker, the patient advocate, and saying, all right, here's what I want to accomplish. Here's my expectations of what I want you to do. And are you capable of fulfilling those? And how many hours? When are you available? What's your response? What's your turnaround? If I call you and say, I'm going into the hospital now, how are you going to respond to that? What are you going to do? How is your availability? And how are we going to pay for this? Are you going to be on retainer? Not likely. Is it going to be, we're going to establish the parameters for how you're going to work. We're going to sit down and work out basically a playbook of what you're going to do. We're going to go through this in intricate detail. And yeah, I'm going to pay for the creation of this playbook. And then we're on hold until I have the event. Maybe we'll never have an event that compels me. Most likely it's going to happen. Most likely you're going to utilize this advocate for all sorts of reasons. And you're billed per the utilization of this advocate for those services. But the point is, whether you're using the law firm's social worker or designated patient advocate, or whether you go out and find a patient advocate, you've got to come up with a series of shopping questions, knowing fully what the expectations are, their availability, their capability, and their track record. What makes you good at what you do? What makes you worthy of being my advocate and representing my interest at a point when I can't fully expect to do that? Why should I trust you? Why should I pay you? It's a question of shopping. And I have helped individuals figure out simply how to access patient advocates, how to take them shopping. The same kind of context of shopping for insurance. What do you want? What are your priorities? And how comfortable and confident do you feel that this person you're engaging with is going to fulfill those expectations, to meet those priorities? You don't just simply say, oh, are you a patient advocate? Oh, will you be my patient advocate? Whoa, this is going to be a long interviewing process. Oh, how important. How important is knowing that in an event where you no longer have the capability of representing your interest or your loved one's interests, how capable is this person of taking you through the process and maximizing the fullest utilization and being honest and realistic and telling you what to expect? These are the kind of things you need to do when you go shopping for a patient advocate. Any other questions?
No, I don't have any questions here, and I didn't see anybody raise their hand or unmute their microphones to ask any further follow-ups questions. So I think that should wrap things up for today. But thank you once again for your time and your expertise. It's invaluable information.
As always, it's been a pleasure working